Shall we get started? Or wait? Shweta, audience, started on live?
Yes, sir. Audience have started to join. You can start, sir.
Okay. Just good evening, ladies and gentlemen. A warm welcome to Secrets of Neurology, episode 45th. We all know it's a knowledge feast for all neurologists, and today's topic is equally interesting. Today's topic is a young man with involuntary movement. Ladies and gentlemen, we are about to reach to the 4th year mark, and today's presenters are from Osmania Medical College, Hyderabad. The reaching of the 4th year mark is purely the work of our program directors. We know Dr. Sudhir Shah sir very well and Dr. Lakshmi Narasimhan extremely well. A warm welcome to both our program directors, sir. Thank you for making it enriching. Thank you for adding value to the field of neurology. As we all know that this program continues for 1 year, beautiful case discussions, interesting case discussions. An honor and privilege for me to introduce our program directors, Dr. Sudhir Shah sir, Professor and HOD at prestigious SMT, NHL, MMC, and SBPIMS Ahmedabad. Sir is also Director of Neuroscience at Sterling Hospital, Ahmedabad. And thank you, sir, for giving the people of Gujarat Chaitanyam, which will cater down to which will have all the leading neurologists of the country. Sir is very well known to all of us, author of 6 books, conferred with most prestigious Padam Shri for his work in the field of clinical neurology, research, and service to patients at large. Sir is also recipient of Dr. V.C. Roy Award and many awards and accolades and interviews and publications to Sir's credit. His interest area is stroke, neurodegenerative disorders, and epilepsy. Thank you and a warm welcome to our second program director, equally man of accolades, Dr. Lakshmi Narasimhan Ranganathan sir, Director and Professor, Department of Neurology at prestigious Sri Ramchandra Institute of Higher Education and Research, Chennai. Many awards and accolades as well. Just to mention a few, Palto CB Advisor from AN, A.B. Baker Award for Global Best Teacher, Best Paper at AN. Sir has made immense contribution to the field of neurology at international and national level. Even today, when he's there, he is delivering a keynote in Calcutta conference. Thank you both our program directors and a warm welcome to our presenters today. May I request our program directors to take it forward from here.
Yes. Good evening and a warm welcome to all of you. At the outset, I must thank and compliment Osmania Medical College Neurology Department headed by Dr. C. Rangalakshmiji, who is a professor. And I must also thank the whole team, that is Dr. B. Archana, that is Associate Professor, Department of Neurology, Osmania Medical College, Dr. Hemant, DM resident, and Dr. Soini, who is also DM resident, for the case presentation and case localization. The topic today is young man with involuntary movements, and I'm sure it would be very interesting to have the deliberation and discussion. Dr. Soini would be presenting the case. Dr. Hemant Karakuntla would give localization details and discussion. Dr. Archana would discuss and dissect the case, and Madam Professor, she will give the summary and conclusion. So thank you very much for your acceptance of this case presentation. Now, as you know, this is the 45th episode, and we are heading towards completion of fourth year of Secrets of Neurology, Knowledge Feast for All Neurologists. And I am very happy, I feel humbled, and I'm honored that this program series has become a very, very well accepted and very much appreciated by all neurologists across the country, from junior neurologists to medical DM students to senior most neurologists also. And as you can see, every time the attendee number crosses 150, 200, and sometimes it is more than 250, let alone Indian neurologists. There are neurologists from US, UK, Canada, European countries, and some other nearby countries also regularly they attend this program. So that is because the texture, the design of the program, and the content and the hard work of all different college professors and students who have made this program so successful. I humbly acknowledge their efforts and their help for making this program a very, very successful series. Not to say less, my co-course director, Dr. Lakshmi Nasihan, is also working very hard to make this program of a very standard level, and we must be very grateful to him. I'm also grateful to all the delegates who have always poured confidence in us, given suggestions from time to time, participated so well, and always have helped us and encouraged us in this great webinar series. Not the least, at the end, I would thank the team of Celestial Division of INTAS, that is Global Cell Division, headed by Mr. Chadda, and of course the team of Dr. Manoj Kumar, Dr. Shweta Chandrakar, and all others who have made this program logistically perfect, and the whole team who has made the networking so powerful. So relentless efforts of all of us, particularly the delegates and the different teams of India, made up of professors and the students, for different case discussions. So thank you once again, and I now would like to request Dr. G. C. Rangalakshmi Madam to take it forward. If I may quickly introduce Dr. Soini, is a second year resident from the same college, and she has Best Paper Award of Epicon in 2019 and Award Proper of TNSCon in 2024. Her area of interest is epilepsy. Next one. Next slide, please. Dr. Hemant is a third year resident, and he got first prize increase in Telangana State Neuros Conference, that is TSNC March 2024. Next slide, please. Madam Dr. B. Archana is the Associate Professor, Department of Neurology, Osmania Medical College. And she has done her MD from Osmania and DM from Nizam Institute of Medical Science, the hometown, that is Hyderabad. Next one. Madam Dr. G. Sri Rangalakshmi is a professor, Department of Neurology, Osmania Medical College. She has done her MBBS from Rangarai Medical College, MD from Guntur Medical College, and DM Neurology from NIMS, Hyderabad. She has publications in various national and international journals. Very kind-hearted lady, and we know her is a very strict personality. So, Madam, thank you once again to you and your team, and I request you to take over from now. And Dr. Lakshmi, do you want to add something to this, or shall we proceed with the case?
Madam, I saw her discussion in the CPC in the recent TNS-Con in Warangal in Karimnagar. She's a very good clinician, sir. As a clinical neurologist, she's one of the outstanding lady. I enjoyed her discussion during the CPC last time. For people who do not know, that Srirangam is a holy shrine of Srirangam. The Sriranga Lakshmi is the name which every Tamilian would be proud of, because the Lord Sriranga is from the Satyalok, sir. The divine God came from the ethics says it comes from Satyalok. And over to Madam for your.
Thank you, sir.
Madam, kindly take over, Madam. Thank you.
Thank you, sir. Thank you for your kind introduction and encouragement. And now I request Sohini to start the case presentation.
Thank you. Good evening, everyone. Today we'll be discussing Good evening, everyone. Today we'll be discussing the case of a young man with involuntary movements. He's a 38-year-old male, resident of Shadnagar, and he's a right-handed individual. He received formal education till 8th standard, and he used to work in a cinema theater. The informant is the wife, and he presented with the chief complaints of involuntary jerky movements of the body and falls since 12 years. The patient was apparently asymptomatic 12 years back. In December 2012, he had a fall from a height of 6 steps and injured his jaw because of sudden jerking of his lower limbs. A month later, in January 2013, on his night shift as a watchman, he was woken up by loud banging on the gate by police. As he tried to get up and walk, he had sudden jerking of his legs and he had a fall. He had 2 similar episodes immediately and sustained a head injury at that time, and it was associated with loss of consciousness and an ENT bleed. He had a deviation of angle of mouth to the left side and inability to close his right eye at that time. He was found to have bilateral frontal contusions, subdural and subarachnoid hemorrhage. He was managed conservatively and discharged on anti-epileptic drugs. 2 months later, he developed 3 episodes of generalized tonic-clonic seizures at night. At this time, he was referred to a neurologist and was prescribed anti-epileptic levetiracetam 500 mg twice daily. He resumed work, but he noticed intermittent sudden jerking of his hands while trying to paste movie posters on billboards and similar intermittent movements in his lower limbs while trying to climb a ladder. But he was able to carry out his activities of daily living at that time. In 2015, he had drug incompliance for 1 day, and he developed sudden jerking of his lower limbs and a fall, sustaining a scalp laceration. He consulted a different center where his anti-epileptic drugs were stopped. When his drugs were stopped, patient noticed an increase in the frequency of the involuntary movements. He was restarted on medication and he had symptomatic improvement for a couple of months. Medication, the frequency and intensity of his movements started to progress after 3 months. He had sudden shock-like movements involving his limbs, distal more than proximal, and the trunk in the form of shrugging of his shoulders. He had involuntary perioral twitchings of the face, which increased while speaking, resulting in a broken speech with reduced clarity. The movements were predominantly present while performing in action and sometimes at rest. They were not rhythmic, they were not suppressible, they were not preceded by any urge, and there was no relief after performing the movement. He did not have any history of any semi-purposeful dance-like movements flowing from one part of the body to another, no flinging movements of the arms, and the movements completely subsided in sleep. They were not aggravated by exposure to loud noise, bright lights, or touch. He walked with the help of a stand till 2016, after which he was progressively unable to walk because of the sudden jerking movements leading to falls. He had difficulty in holding a brush, buttoning his shirt, and negotiating his foot into trousers because he had multiple sudden jerks every time he tried to perform an action. He required multiple attempts to hold a food bolus, but was unable to guide it into his mouth due to the movements. In 2017, his wife noticed posturing of his hands, involuntary sustained posturing with flexion at the wrist, metacarpophalangeal and proximal interphalangeal joints. He was evaluated at multiple hospitals, and medications were added progressively over the years between 2017 and 2023 with increasing doses. Patient had some symptomatic relief in the form of decreasing in the frequency and amplitude of movements, but this improvement was short-lived. He continued to progress despite regular medication to the present state. He is confined to the bed and dependent for all his activities of daily living. He is unable to stand or shift himself in bed. The movements increased in frequency at rest, and slight movement would result in generalized uncontrollable jerking of his body. The patient is currently on tablet tetrabenazine, trihexyphenidyl, clonazepam, valproate, and levetiracetam at the above doses. He did not have any history of any tightness or looseness of limbs. There was no history of muscle thinning or fasciculations. He did not have any history of slowness of activities or expressionless face. There was no history of any sensory or cerebellar disturbances. He did not have any bowel or bladder disturbances or any autonomic disturbances. There was no history of any decreased smell, decreased vision, double vision, decreased facial sensations, or difficulty in chewing. There was no history of dysphagia, hoarseness of voice, or nasal regurgitation, and no history of difficulty in clearing the food from the vestibule. He did not have history of memory disturbances. There was no visuospatial dysfunction. He was able to perform simple calculations, and he was able to recognize faces. He had history of hopelessness and worthlessness, and a history of feeling depressed about his disability, but there was no history of any suicidal ideation or mania. He did not have any history of weight loss, loss of appetite, exposure to drugs and toxins, usage of antidepressants and antipsychotics. He's not a diabetic or a hypertensive. He did not have any history of cardiac disease or tuberculosis or asthma. Personal history, he takes a mixed diet. His sleep is normal. His appetite is normal. And he's an occasional alcoholic and a smoker. There was no significant family history. He is born out of third degree consanguineous parentage, and there are no similar complaints in the siblings or his children. So summarizing the history up till now, a 38-year-old gentleman with chronic progressive neurological illness with generalized action myoclonus, dystonia of upper limbs, orofacial dyskinesias without sensory, cerebellar, autonomic, cognitive, or any family history. Now I would request Dr. Hemant to analyze the symptoms.
What about the GTCS?
He had only one episode of generalized tonic-clonic seizure, sir. And in these 12 years, he did not have GTCS again.
And that should be, that's also part of the
Yes.
fact that he had a seizure. That should also be included in the summary.
Yes, sir.
Thank you.
After history, we have a syndrome of multifocal action myoclonus with dystonia, with one episode of seizure, which is of adult onset and progressive in nature. Next, I want to characterize these movements as well as localize them. Next slide. Next slide. These involuntary movements, which were brief, jerky, shock-like, sudden, without any posturing, without any urge or without any relief of tension after the movement, I would like to consider myoclonus. These involuntary movements were involving lower limbs, upper limbs, trunk, and not simultaneously. So considering not simultaneous involvement of these body parts, I would consider multifocal myoclonus. These actions were occurring during walking, eating, or doing any kind of action myoclonus. Though there was sudden brief shock-like jerky movements at rest, they were far less outnumbered by action myoclonus, and they were subtle, and the frequency was on lower side. There is no significant history of stimulus sensitivity, though in history we have an episode where after sudden banging of the door, there was sudden brief jerky movements of the lower limbs, but there is no other history to corroborate stimulus sensitivity. Considering multifocal action myoclonus, I want to localize it to the cortex. Focal dystonia, I would localize it to the subcortical structures, basal ganglia, and its connections. Next. So considering a syndrome of adult onset dystonia and myoclonus, which is progressive, this is a list of all the causes which can cause such a syndrome. So considering infections, CJD, Whipple's disease, HSV, Japanese encephalitis, HIV, all these infections can present with similar syndrome of dystonia and myoclonus, though 12 years history and non-involvement of the other organs, as well as no encephalopathy, no other semiology of seizures, it is less likely that infection is a cause of this syndrome. Next, considering autoimmune disorders like celiac disease. Celiac disease, generally the gastrointestinal manifestations occur prior to the neurological manifestations. Even if the neurological symptoms are the first symptom, the prominent symptom is cerebellar ataxia. Prominent symptom is ataxia. So considering steroid responsive encephalopathy with autoimmune thyroiditis, throughout 12 years history, there has been no history of encephalopathy even once for us to consider street. Considering other autoimmune encephalitis, which are chronic, like Igilon 5, we have seen cases being described even after 12 years of onset of symptoms, and DPPX. Igilon 5, to consider Igilon 5, we do not have REM sleep behavioral disturbances, dysphagia is not prominent, and Parkinsonism is also not prominent. Considering DPPX, there is no diarrhea, there is no history of peripheral nerve hyperexcitability, and considering other autoimmune disorders like LGI1, Casper, GABA A, GABA B, without involvement of other cognition or encephalopathy or other type of seizures, they are unlikely to explain this current syndrome. Then considering other causes like Golgi-related disorders, which is a mitochondrial disorder with no associated proximal myopathy, no neuropathy, with no migraines, with no history of any lipomas, without any vision loss, or without any hearing impairment, it is unlikely that Golgi is a cause for the above syndrome. Niemann-Pick disease type C, it can present in adult age and can have predominant neurological manifestations. Yes, it is a possible differential diagnosis, and we will discuss it further. Adult onset Tay-Sachs disease, it can present with presentation of either motor neuron disease or pure dystonia or spinocerebellar ataxia. But in our syndrome, it is predominant action myoclonus with dystonia. NCL, neuroceroid lipofuscinosis type 4, Coop's disease, is a possibility in this patient where they have predominant cortical action myoclonus, and that can progress continuously over 1 to 2 decades. Considering Kupffer-Rackheb syndrome, Kupffer-Rackheb syndrome is a part of NBIA, and presence of prominent Parkinsonism symptoms are generally seen in Kupffer-Rackheb. The age of onset is 10 to 20 years of age. Then considering trinucleotide repeat diseases like Huntington disease, Huntington's predominantly has chorea as its manifestation. Here, there is no history suggestive of chorea. Adult onset myoclonus and dystonia is the predominant syndrome we are having. So less likely to be Huntington's, even if we consider juvenile Huntington's can have seizures as a manifestation, though myoclonus is rare, but the age of onset is generally less than 20 years of age, where we have in 4th decade. Spinocerebellar ataxia, 1, 2, 3, 6, 7, 14, 17, and 19 can present with movement disorders and dystonia also, dystonia with myoclonus, but absence of ataxia, cerebellar ataxia, it is unlikely that the causative cause for this syndrome is DRPLA is a possible cause, which we'll be discussing further in the coming slides. So from that broad differential diagnosis, this is my list of differentials in the order of priority. First, I would like to consider Couf's disease, NCL type 4, adult onset. Next, Wilson's disease, Unverricht-Lundborg, Niemann-Pick disease type 4 as my fourth differential, and DRPLA as my fifth, and sialidosis as my sixth differential. So considering each disease in detail, Couf's disease in an adult onset, the age of onset is generally around 30 to 40 years. Yes, but the age can extend from teenage till 50 years of age. There is marked myoclonus, especially action myoclonus, which is the significant symptom sometimes patients presents to a neurologist. There is associated dystonia. There is no visual involvement unlike the other NCLs. There is progressive epilepsy, predominantly myoclonus. Considering these points, I have put it as my first differential. However, we need to consider that dementia which is described and which is common in Couf's is not significant in our patient. Ataxia can be present, and also it can the Couf's has a spectrum of presenting from progressive myoclonic epilepsy to progressive myoclonic ataxia, where progressive myoclonic ataxia has myoclonus as a predominant symptom and dementia is milder compared to progressive myoclonic epilepsy. Considering Wilson's, any patient with movement disorder who is less than 40 years of age, I would like to consider Wilson's in the differential because it is a treatable condition. Points for the diagnosis are dystonia and age of less than 40 years, and it being treatable, I would like to consider it. However, the most common age of presentation is generally second degree with Parkinsonism symptoms, and psychiatric manifestations are generally seen in 30 to 40%. Seizures are rare, and myoclonic seizures are even rarer in Wilson's disease. And even if there is myoclonus, presentation as a myoclonus and myoclonus being the predominant symptom for 12 years is unlikely. And absence of characteristic tremor, wing beating tremor is absent. Unverricht-Lundborg is the most common NCL. Action myoclonus, and which is predominant while walking. In our patient, we have myoclonus which is predominant on walking, and he is not able to walk, he is debilitated, he is bedbound. And associated dystonia is also present. Facial myoclonus is also present, which is making his speech intelligible. So considering these points, I have put Unverricht-Lundborg as my third differential. However, we need to consider that the age of onset is first to second decade, 16 to 15 years, though later of ages of onset can also be present. Reflex myoclonus stimulus sensitivity is prominent in Unverricht-Lundborg, which we don't have in our patient. Diurnal variation and photosensitivity is also described in Unverricht-Lundborg. The history is typical that when seeing a television TV or when facing flashing lights, they experience myoclonic jerks. And the general presentation to your neurologist is because of a GTCS semiology. They have cascade seizures where multiple myoclonic jerks ultimately lead to a GTCS, and that is the reason for presentation to a doctor. And these symptoms in Unverricht-Lundborg, they generally stabilize by 5 to 10 years of age, and there is subtle improvement can also be seen in Unverricht-Lundborg, which is not the case in our patient. Considering Niemann-Pick disease type C, it is adult onset, pure neurological type can be present, myoclonus where upper extremity is more involved, perioral myoclonic jerks, distal myoclonus is prominent, dystonia is present, dysarthria is present, and seizures are present, progressive epilepsy is present. Considering these points, I have put Niemann-Pick as a differential. But however, we need to consider absence of ataxia, cerebellar ataxia, and also dysphagia, absence of dysphagia in spite of 12 years of history is unlikely to explain Niemann-Pick. Psychiatric manifestations are also common in Niemann-Pick, around 40 to 50%, and absence of cataplexy is also a point against the diagnosis of Niemann. Another differential I would like to consider is DRPL. Age of onset, 4th decade, myoclonus and dystonia, but there is no family history, no significant cognitive impairment, no history suggestive of other movements like athetosis, chorea, tremor, or even ataxia is not predominant. DRPLA can have 3 presentations. One is pseudo-Huntington's, another is progressive myoclonic ataxia, where myoclonus being the predominant symptom with ataxia, and other is cerebellar ataxia predominant. So in our patient, we had, though we had myoclonus and dystonia, the absence of significant family history and the cognitive impairment goes against the DRPL. The last differential I would like to consider is sialodosis. There is high frequency myoclonus, prominent gait disorder. They are unable to walk. They are debilitated, wheelchair bound because of myoclonus involving the legs. And the similar kind of presentation is seen in our patient. Though dystonia is not described in literature for sialodosis, and age of onset is also younger, less than 30 years, and they generally have significant cognitive impairment, which is not there in our patient. These are the differentials we have put forward for this case. Now I request my colleague, Dr. Sohini, to start from examination.
Thank you, sir. On general examination, the patient is conscious and coherent. There was no pallor, icterus, cyanosis, or clubbing. His blood pressure was 120/80 millimeters of mercury in supine position. His pulse rate was 84 beats per minute. There were no neurocutaneous markers and no KF ring. On other system examination, respiratory, cardiovascular, and gastrointestinal system examination was normal. CNS examination proper. The patient is a right-handed individual. He received formal education till 8th standard. His MoCA score was 10 out of 30. Higher mental functions, his forward digit span was 3, backward digit span was 2. Fluency was normal. His comprehension, 2-step comprehension was present. Reading and naming were normal, and writing couldn't be tested because of the myoclonic jerks. On testing of the frontal lobe, judgment and insight were present. Test for response disinhibition, the go-no-go test was normal and Stroop test was normal. Trial A and Trial B test couldn't be done because the patient was not able to hold a pen. His fluency, his pass score is 7 and categorical fluency was 10. Motor and graphic sequencing couldn't be done. Both his verbal similarities and proverb interpretation were abnormal. And on testing for sustained attention, TAP-A test was normal and random letter cancellation tests couldn't be tested. On parietal lobe functions, tools for conceptual apraxia, tool selection and alternate tool selection test was normal, and gesture recognition was normal. Ideational and ideomotor apraxia couldn't be tested. He did not have any right-left disorientation or any finger agnosia. Line bisection, simultagnosia couldn't be tested, and constructional apraxia couldn't be tested. On testing for memory, his immediate memory was normal. Recent memory, at 1 minute, he was able to recall 2 out of the 5 objects given. At 5 minutes, he was not able to recall any of them. And with queuing, he was able to recall 1 out of 5. His remote memory is normal. And occipital lobe testing, he did not have any prosopagnosia, and color identification was normal. So at the end of lobar function tests, he had some frontal and temporal lobe impairment was present. His speech, he had loss of prosody and slow and broken speech. I'm going to share a few videos of the patient after taking informed consent. So this was the speech of the patient.
ఎంత వయసు ఒక్కొక్కరిది చెప్పు స్కూల్కి వెళ్తున్నారా? ఎక్కడ స్కూల్లో? షాద్నగర్ లోనేనా?
We can see that the patient's speech is fragmented and broken because of the involuntary movements. Coming to cranial nerve examination, first cranial nerve was normal. Second cranial nerve, visual acuity, visual fields, and color vision was normal bilaterally. Fundus was normal. There was no cherry red spot. On examination of the third, fourth, and sixth cranial nerves, pupils were normal size, reacting to light. He had vertical gaze restriction, down gaze more than up gaze. He had vertical gaze restriction, as we can see in the video. Down gaze was more restricted than the up gaze. On testing for saccades, he had there was increased latency of the saccades, as we can see in the video. The saccades were slow and hypometric. Even the pursuit movements were smooth, convergence was present, and the vestibulo-ocular reflex was normal. The fifth cranial nerve examination was normal. Seventh cranial nerve, he had traumatic right lower motor neuron type of facial palsy 12 years back when he had the trauma. He has some residual deficit from that. And the left side, it's normal. Eighth cranial nerve with air conduction was more than bone conduction. Renice was positive and there was no lateralization on Weber's. And ninth and 10th cranial nerve testing, uvula was central and palatal arches were moving equally with phonation. He had palatal myoclonus was present. There were no audible clicks. And this is a video of the palatal myoclonus that the patient had. As we can see. 11th cranial nerve was normal. 12th cranial nerve testing, side-to-side movements of the tongue was slow. Tone of the tongue was normal. He had tongue dyskinetic movements were present. We can see the patient had motor impersistence also. He was not able to protrude the tongue for more than 10 seconds. And there were multiple continuous dyskinetic movements of the tongue. The bulk was normal, there was no waste, and tone is normal in all limbs. Power was 5/5 in all. Superficial reflexes, corneal and conjunctival reflexes were present, abdominal reflexes were present, plantars were flexa bilaterally. Deep tendon reflexes, biceps, triceps, supinator, knee, and ankle were 2+ bilaterally. Sensory examination was normal. Pinprick and joint position and vibration sense was normal. And coordination. This was the finger test where the patient, because of the severe jerking, he was unable to do this test. There was no nystagmus, no titubation or rebound phenomenon. Tandem walking and dysdiadopakinesia couldn't be assessed. On examination of the extrapyramidal system, his blink rate was 10 per minute. On finger tapping, there was decreased amplitude and speed of the movements. There was no cogwheel rigidity. Primitive reflexes were absent, and he had bilateral striatal toe was present. He had sudden shock-like jerking movements on involuntary movements. He had sudden shock-like jerking movements present involving the upper and lower limbs, distal more than proximal, and the trunk. And these movements were present predominantly at performing an action and also sometimes at rest. And dystonic posturing of bilateral hands was present. So this is the patient at rest. we can see that the patient has subtle involuntary jerking of his hands and his legs. So he has multifocal myoclonus, and this is the dystonic posturing of the hands and the fingers. The patient did not have any wing beating tremor. So this is a video of the severe action. So this is the gait of the patient. The patient cannot stand without 2% support because of the involuntary jerking movements of his trunk and his lower limbs, which leads to falls. Now I would request Dr. Hemant to take over for analyzing the symptoms after examination. So you're not audible.
After history and examination, we have next slide. So we have myoclonus, which is action myoclonus, multifocal. I would localize it to the cortex. Dystonia and extrapyramidal involvement, I would localize it to the basal ganglia and its connections. Vertical gaze restriction, where down gaze is more restricted than the up gaze, I would localize it to the midbrain, RIML. Slow saccades, I would consider dorsal vermis involvement. Palatal myoclonus can be because of the either brainstem involvement, dentato-olivary tract involvement, or can be part of the generalized myoclonus. Similar with tongue myoclonus, it can be because of brainstem involvement, whereas dentato-olivary tract involvement are part of generalized myoclonus. Guillain-Mollade triangle involvement can give rise to both of these, palatal myoclonus as well as tongue myoclonus. Next. So after history and examination, the structures involved are cerebral cortex because of action myoclonus, which is multifocal, localizing it to the cortex. Basal ganglia because of dystonia and extrapyramidal involvement in way of slowness of finger tapping, and striatal toe. Brainstem, it could be because of palatal myoclonus and tongue myoclonus. We can localize it to the brainstem, and cerebellar involvement because of the slow saccades. Considering the history and examination findings, the possible differential diagnosis I want to consider are three. First is Cook's disease. Second is Niemann-Pick type C. Third is DRPLA. After examination, we have vertical gaze restriction, which is down gaze is more restricted than the up gaze, and slowing of horizontal and vertical saccades. This is not well described in Cook's and is not described in literature for Cook's disease. But still, I want to consider Cook's as my first possibility because of action myoclonus, which is predominant symptom and which is progressing over 10 to 12 years. Yeah, the second differential is Niemann-Pick disease type C. After examination, we have vertical gaze palsy, where down gaze palsy is prominent than the up gaze, and slowing of saccades. These examination findings point more in favor of Niemann-Pick disease type C. Hence, I want to consider it as my second differential. DRPLA can also present with vertical gaze palsy, where down gaze is more restricted than the up gaze, with slow horizontal and vertical saccades. So this is my third differential because of the vertical gaze palsy and slow horizontal and vertical saccades. Now I would like to request Archana ma'am to carry on from.
At this juncture, may I ask Dr. Sohini or Emnath, what was the physical findings of liver and spleen?
There was no organ anomalies.
Any other examination, general examination finding?
No, sir. All the findings have been put in. There are no extra general examination findings we have.
There was no cherry red spot and no organomegaly in the patient, sir.
Kindly proceed.
Yeah, good evening, everyone. So proceeding further with the workup, am I audible? So proceeding further with the workup, we had the differential of Kuff's disease and Niemann-Pick disease type C and DRPLA after examination. So in any, it's a young patient with myoclonus and dystonia. So any patient with myoclonus and dystonia, there are some treatable causes which we need to consider. So we also considered them. So considering these 5 treatable causes is very important because patient there's always chance for improvement. So first thing, tyrosine hydroxylase deficiency, which can present in the form of food dystonia, dopa-responsive dystonia. You can occasionally, rarely present with myoclonus at the onset. It has a childhood onset with diurnal variation and with food dystonia. But in some cases where myoclonus is present at the onset, they need not have diurnal variation. Female preponderance may not be seen. The only thing which we need to check is the levodopa responsiveness, which we have done. And there was no responsiveness. Patient did not, the myoclonic jerks did not respond to levodopa. There was no significant improvement after levodopa trial. So we did not further consider this differential. Then the other differentials which we also consider because they have treatment is cerebrotendinous xanthomatosis. The prominent feature in cerebrotendinous xanthomatosis is ataxia, again cerebellar ataxia with intellectual disability and psychiatric symptoms. Onset is in the early second decade. The prominent examination finding is tendon xanthomas. Anyone who sees once will not forget it, will definitely identify. And MRI also shows certain characteristic abnormalities where you have a T2 hyperintensity or hypointensity in the basal in the cerebellar hemispheres, dentate nucleus. So this also, the patient did not have any tendon xanthomas and the presentation is also different. So we did not consider this also. Then GLUT1 deficiency, usually it has an infantile or childhood onset with drug-resistant seizures, paroxysmal movement disorders, occasionally can present with myoclonus. But as there are no other features, we did not consider this also. So left out Niemann-Pick type C, we already considered after examination, and Wilson's is one, even though there are no characteristic features suggestive of Wilson's, still because it's a treatable cause, we wanted to rule out Wilson's disease. Even on fundus exam, on
Ma'am, would you like to continue? I think we lost Dr. Viarchana's. There must be some connectivity issue.
They will try. I think she'll be trying to rejoin. We'll see. We'll wait. Wait for a minute and see. Otherwise, we'll ask Madam to give her thoughts, Sriranga Lakshmi to give her thoughts, and then once she comes back, we can always ask her to continue. Regarding the chat question, there are a couple of questions in the chat. The question and answers. One is the one question is were pursuits normal, or the patient have palatal myoclonus? Yes, patient had palatal myoclonus. Was the pursuits normal?
Yes, sir. Pursuit movements were normal, sir.
Normal. Okay, fine. So there's somebody has asked us SGC mutation. Why not a possibility? I don't know.
There was no alcohol responsiveness in this patient, sir. It usually involves the upper limbs, and the patient had more of a generalized.
What is this SGC mutation? For the sake of any idea.
DYT11, I think.
So that is DYT11, sir.
Okay.
And it starts in the upper limbs. Lower limbs are not affected. And the characteristic dystonia is cervical dystonia as well as writer's cramp, sir. Both are not seen in this patient.
Okay. So it's unlikely to be SGCA mutation. So these are the questions you asked.
Audible, ma'am?
Yeah. You're well audible. Continue.
Shall I start from the beginning? I was not sure.
Yeah, treatable cause. You are
treatable cause.
Since you're considered. Until that, we enjoyed your talk.
Okay, ma'am. Okay, sir. So on MRI, patient did not have any evidence of hyperintensities in the basal ganglia, midbrain, or pons. What he had is caudate atrophy, prominent caudate atrophy, if you can see, and also some frontal lobe hyperintensities, which was related to the previous head injuries. There was gliosis of both the frontal lobes because of repeated head injuries. The second differential we considered was Niemann-Pick type C disease. Already it was discussed, the points in favor and against. So investigations wise, we have done LFT, which was normal. There was no evidence of any cholestatic jaundice. CBP was normal. There was no evidence of any hypersplenism. Lipid profile was normal. Some cases of Niemann-Pick type C may show low HDL levels, which was not there in our patient. So there were no points on these preliminary investigations in favor of Niemann-Pick type C disease. Then ultrasound abdomen has not revealed any organomegaly. There was no splenomegaly or hepatomegaly. MRI brain, as there was some cortical atrophy was present and SCPs were normal. There was no giant SCP. So MRI, it's not very specific in case of Niemann-Pick type C. Might show some cortical atrophy. That's the only one point which is in favor of Niemann-Pick type C. Even though after examination he had many points in favor of Niemann-Pick type C, like vertical gaze restriction, down gaze palsy. All those are in favor of Niemann-Pick type C, but investigations wise, we did not find much of points in favor of Niemann-Pick type C. Coop's disease, after examination, we had some points in favor of the disease and some points like there was no dementia or ataxia and there is no vertical gaze restriction. Already it was discussed. So investigations wise, MRI was showing, as I pointed already, was significant cerebral atrophy and caudate atrophy was there, and there was very minimum cerebellar atrophy. Only in the midline sections we are able to appreciate some cerebellar atrophy. And as noted, there is also some thinning of the corpus callosum. The EEG, it had normal background and there was no photoparoxysmal response. And there were generalized discharges, spike and wave discharges, some evidence of polyspikes is also there. So the patient had myoclonic jerks involving the left upper limb where they had the correlating EEG discharge spike and wave on the right side and the movement artifacts were there on the left side. So right side you have the discharges and left side is the movement. So after investigations, again, points in favor of Coop's, EEG might show focal and generalized epileptiform discharges. But however, it also, background slowing is also described in Coop's disease, which our patient doesn't have. And there was no photoparoxysmal response in our patient, which is characteristically described for Coop's disease. And SCP, there's no giant SCP, which is described for the Coop's disease. Then MRI brain can show cortical, subcortical, varying amounts of cortical and subcortical atrophy and thinning of corpus callosum, which was there in our patient. But there is not much of cerebellar atrophy, which is also described in Cook's disease. In fact, some cases they have found that cerebellar atrophy is more marked than the cortical atrophy. And white matter hyperintensities in a parieto-occipital area are also well described in Cook's disease, which is also not seen in our patient. So there are few points in favor of Cook's disease and there are few points against Cook's disease in our patient. DRPLA, the third differential diagnosis, which was considered after examination. So the onset in late fourth decade with myoclonus dystonia, with some gaze palsies, all those favor. But DRPLA, it's very rarely described outside Japan. And this patient did not have positive family history. So those are 2 points really against diagnosis of DRPLA. So, and scan did not show significant cerebellar atrophy. It is the course of the disease is 12 years, but there is not much of cerebellar atrophy. And gliotic changes, we thought it is related more to the previous trauma. And other investigations, EEG was showing, as previously described, focal and... Hello? Am I audible, sir?
Yes, ma'am, you are audible.
EEG was showing focal and generalized epileptiform discharges. Whereas again, same points, no background slowing and no photoparoxysmal response. Those are the points against DRPLA. And giant SCP was not seen. And MRI was not showing much of cerebellar atrophy. So same points which are against the DRPLA. So other investigations we have done in this patient is an iron profile, which was normal. And the 2D echo, which was showing only concentric LVH, nothing else, EF of 64%. Serum lactate was normal and vitamin E levels was normal. Sometimes vitamin E deficiency can present with the myoclonus and ataxia, but other features like ataxia, peripheral neuropathy, optic neuritis, all those are not seen, but still it's a treatable cause. So we also done vitamin E levels, which are normal. Serum lactate, thought of mitochondrial also at one point. So we thought of that and got a serum lactate levels, which is also normal. ANA profile was also normal. So this is the video EEG. This also you have the onset of myoclonic discharges on the left side corresponding with the right side spike and wave discharges becoming generalized. Occasionally occurring only on the left side, sometimes on the right side. And SCP, the P25 amplitude is less than 5 microvolts. So no giant SCP was there in this patient. So other differentials we also considered were any patient presenting with myoclonus dystonia. The first differential which we get is the DYT11 dystonia, but the age of onset is first decade. And the myoclonus is usually described in the upper limbs. Lower limb onset myoclonia is highly uncommon in DYT11. And the dystonia which is described in DYT11 is cervical dystonia and writer's cramp, and not the upper limb dystonia which we have got in this patient. And the patient occasionally consumed alcohol, but there was no alcohol responsiveness in our patient. And the MRI brain, it described to be normal in these DYT11 patients. In our patient, MRI was not normal. It was showing caudate atrophy, some cerebellar atrophy, cerebral cortical atrophy, all this. And there was no giant SCP. So there are so many points against the diagnosis of DYT11. So we did not consider, initially we considered, but because of all these odd points, we did not consider DYT11. And the other thing which was already discussed, juvenile Huntington disease. Seizures as presenting feature is seen in 15% of the juvenile Huntington disease. Myoclonus even more rarely described as a presenting feature. Psychiatric problems, chorea, Parkinsonian features, all those are described, which are not there in our patient. And the only point in favor in our patient is the atrophy of the caudate nucleus, bilateral caudate nucleus atrophy, which is seen very prominently in our patient. So that was one point in favor of juvenile Huntington's disease. And the other one, NBIA, Kupffer-Jacob disease, already it's been described. More younger age of onset with the dystonia Parkinsonism or isolated Parkinsonism. Dystonia usually described as a craniocervical dystonia, not the hand dystonia. And MRI was also not showing the eye of tiger sign. So that's why we did not consider further. Unbridged Lundberg was already discussed, and EEG was not showing any photoparoxysmal response. So myoclonic epilepsy with ragged red fibers, he did not have any other systemic symptoms, neuropathy, myopathy, cardiomyopathy, hearing loss. None other features were present in our patient. So we did not consider. We have done serum lactate levels which were normal. Sialidosis, there was no cherry red spot or no dysmorphic features. The EEG was also not like a sialidosis where you have a generalized periodic discharges. So, so we were stuck at this point. So all the investigations which we have done, we did not find nothing characteristic of any of the differential diagnoses we considered. So we proceeded with the whole exome sequencing and also we sent the CAG repeats also. The results are being awaited because we have sent, I think, 2 weeks back or something. It takes some 5 weeks for the results to be out. Thank you, sir. Any questions are there?
This is like a suspense. This is like a thriller movie where you are kept as the serial. They say continue next week. that kind of all of us are expecting what is this? We're all breaking
yeah,
our heads.
Yeah, yes, sir. So it's very difficult to convince the patient for genetic testing, sir. So
I
in
understand.
our setup,
I understand, and that too in a governmental setup, and that place the kind
they
of
were not
workup which
ready,
you have done
sir.
is remarkable. It's remarkable and a wonderful clinical case and beautifully, very, very beautifully discussed. And I want Madam, what is Madam's comments, Madam?
Yes, sir.
Concluding remarks, Madam.
Yes, sir. This is very tough case, sir. He came only 3 weeks ago. We were able to do all those tests that are available, but could not find a cause because, as already discussed by Archana and Hemant, am I audible, sir?
Yeah, you're audible.
Excellently discussed, and why we presented this case, even though genetic testing is not available, is to make aware of the residents to approach a patient with myoclonus because we don't see it so frequently. We discuss all dementias, atypical Parkinson's, all those things. But how to approach a patient with myoclonus, it is very difficult because we don't see them much often. So our patient with lower limb onset of myoclonus leading to falls.
Almost life-threatening injuries he has sustained.
Yes,
and, and more important is one more thing is all the clinical findings will also be complicated by the trauma.
Yes,
trauma.
Sir.
How much is the disease is going to contribute? How much the trauma is the post-traumatic sequelae? Also, we really know. But I felt that such a big squaring of the caudate nucleus, the caudate head atrophy is significantly.
Yes, sir.
I mean, that is what. So my first bet would be on. I don't know. I would bet on. Even though the features are atypical, I would put my bet on juvenile Huntington's.
Yes, sir. A typical presentation of juvenile Huntington's, sir.
Huntington's is my first bet. That's what I thought.
But even this combination of generalized myoclonus with palatal tremor or myoclonus, is it so common, sir? Both in the same patient.
Very, very rare. Very, very rare. But and one more thing, tongue, madam, acanthocytes were not there. La?
There were no acanthocytes, sir.
Okay. Somebody has asked some questions. 1 minute, madam. I'll just go to ask you the questions. And is there any possibility of immune encephalitis related myoclonus symptoms? Dr. Divakar Reddy.
Sir, we thought of autoimmune encephalitis. Yes, sir. Autoimmune encephalitis can sometimes present with myoclonus, especially this Caspr-2, anti-Caspr-2 antibody encephalitis can present with lower limb myoclonus. But it will produce severe neuropathic pain, which is not seen in this patient. And the duration is 12 years. That's why we could not consider. Even the myoclonus is seen in anti-Caspr-2, GABA receptor encephalitis, DPPX, and opsoclonus myoclonus syndrome. He is not having any opsoclonus. So autoimmune etiology is less likely in this patient, sir.
Then one more, chronic traumatic encephalopathy, any feature of cavum septum pellucidum. Sandhya Manoranj.
There is no persistent cavum septum pellucidum, and his myoclonus started even before trauma, sir. Because of the trauma, he sustained injuries, and myoclonus was the first symptom rather than trauma causing myoclonus, sir. So post-traumatic, we are not considering.
possibly considered other SSP sometimes can prolong survival. The features doesn't fit in with that.
SSP
CSF analysis done.
CSF analysis is normal, sir. SSP, the EEG is not like SSP. Even after 12 years, we did not get any periodic complexes. Sir.
Was CSF done in this case?
CSF was done there, normal. I think she did not project. Okay. It is normal, sir.
So all the questions have been answered. Is there anything else from our side to be left? Nothing.
And we are waiting for the genetic reports, sir. We will let you know in the next meeting.
Sure. Thank you, madam, for the excellent presentation. Alexander, somebody consider Alexander. Somebody wants to know myoclonus, long-term sequelae of post-HSV encephalitis. So these are the few thoughts of others. Anyway, thank you so much, madam. Thank you. If there was anything else, madam, otherwise we will close the session. My sincere thanks for the entire team. Wonderful presentation, madam. Thoroughly enjoyed every one of you. The discussions of the residents and I'm very grateful to you for giving an intellectual feast. Thank you.
Thank you, sir. Thank you for this opportunity.
Okay, over to the organizers. Thank you.
Thank you so much, sir. Hello, everyone. I hope you all are doing well. Today marks a special occasion as we wrap up the 45th session of Secrets of Neurology. On behalf of Intas Pharmaceuticals, I, Shweta Chandrakar, want to extend a heartfelt thank you to all our wonderful delegates who have been with us on this incredible journey for the past 45 months. A big shout out to our esteemed course directors, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir, for putting together such an amazing web series on neurology. It's been a valuable resource for DM and DNB students across India and many other countries also. I also want to express my gratitude to Dr. Sohini for her enlightening case presentation, Dr. Heman for his thorough case localization, and Dr. B. Archana ma'am for her meticulous symptom evaluation, investigation, and literature review. Special thanks to Professor Dr. Sri Rangalakshmi ma'am from Osmania Medical College, Hyderabad, for sharing her invaluable experience and insight with us. Thank you all for joining us today. It's been a pleasure having each and every one of you at the 45th session of Secrets of Neurology. We look forward to seeing you again on 26th April 2024 for our next much awaited sessions. Until then, stay safe and take care. Thank you so much, ma'am.
Thank you, Sweta. Good night to all.
Good night. Thank you, Archana ma'am. Thank you, Dr. Heman. Thank you, Dr. Sohini.
Thank you.
Good night, ma'am.
Rohan? Hello, sir. Good
Yes,
night,
ma'am.
sir.
Bye. Good night to everybody.
Good night, doctor.
Rohan, we can close.